Hello everyone, welcome to my YouTube channel. This is Dr. Naz and today I am reviewing about ACLS, and this presentation is going to include some rhythms and the algorithms which are important in ACLS and some important points to remember for exam. So be with me. First of all, we need to know about this chain of survival, and there are two settings: outside the hospital and inside the hospital. Outside the hospital, the first one is activation of emergency response system, then start high quality CPR, then defibrillation, advanced resuscitation, post cardiac arrest care, then recovery. In hospital, it is early recognition and prevention, then activation of emergency response, high quality CPR, defibrillation, post cardiac arrest care, and then recovery. So you all must be aware with ABC, that is airway, breathing and circulation, but now it has changed to CAB, that is circulation first, then airway, then breathing. When we approach to a victim that is suffering from cardiac arrest, we look for the scene safety first because our safety matters too. Then we ask for responsiveness, check the pulse, and then breathing. It should take at least 5 seconds but no more than 10 seconds. It's an important point for exam point of view. Call for help and activate emergency response system and start high quality CPR. Then ask someone to bring an AED, then you can defibrillate the patient and then shift the patient when help arrives. So in this slide, basically I have summarized whole ACLS algorithms, and if you pay attention to this slide, you will be able to clear the exam. So first of all, we have to see the pulse. In any patient arriving to you or any victim, you need to see pulse. If the pulse is present, then the scenario will be different, and if the pulse is absent, which is known as cardiac arrest, then you have to perform differently. So if the pulse is present, rhythm can be either bradycardia or tachycardia. Bradycardia means slow heart rate and tachy is increased heart rate. After the pulse, and you have to check symptoms and hemodynamic stability. How to check hemodynamic stability? By looking at the patient's blood pressures. So if blood pressures are more than 90 millimeter of mercury, systolic one I'm talking about, then it will go to medical management, and if it's less than 90, it means it's unstable patient, so we will proceed with other interventions. So for example, in case of bradycardia, you will see symptoms, and symptoms can be anything. It can be decreased blood pressure or hemodynamic instability, altered level of consciousness, any chest pain or signs of acute coronary syndrome, so it can be anything. So if the symptoms are present, then you have to give atropine, and simultaneously you can go for transcutaneous pacing and dopamine infusion or epinephrine infusion. And if the patient is asymptomatic, then you have to just observe the patient. Same goes for tachycardia. It is tachycardia. It includes atrial fibrillation, atrial flutters, and ventricular tachycardia with a pulse, supraventricular tachycardia. Everything comes into this domain except for pulseless ventricular tachycardia, which will go into cardiac arrest. So if the symptoms are present, then you will directly go for synchronized cardioversion, and if the symptoms are not there, then you will have to see the rhythm and analyze the QRS complex. If the QRS complex is more than 120 milliseconds, then and you see the rhythm is regular, then you will give adenosine or anti-arrhythmic drugs. Any anti-arrhythmic can be given, either amiodarone or lidocaine. If QRS complex is less than 120, then you will perform vagal maneuvers and give adenosine, calcium channel blocker or beta blocker. Next is cardiac arrest. Cardiac arrest is absent pulse. If the patient has no pulse, then the patient is in cardiac arrest. There are two types of cardiac arrest. One is shockable rhythm, and the other unshockable rhythm. In shockable rhythm, you have ventricular fibrillation and pulseless ventricular tachycardia. And in your non-shockable rhythms, you have asystole and pulseless electrical activity. So because these are shockable rhythm, ventricular fib and pulseless VTAC, we will have to give shock. If your monitor is showing these two rhythms, you have to give shock anyway because it's the definitive treatment. So what's the algorithm? Shock, shock, epinephrine, shock, antiarrhythmic, then shock, shock, epinephrine, then antiarrhythmic, then you have to repeat shock, shock, epinephrine. After 2 shocks, epinephrine, then 1 shock, then antiarrhythmic. So you have to repeat this until you achieve return of spontaneous circulation. In asystole, which is a non-shockable rhythm, so you don't have to give any shock. It's just about 2 things. One is CPR and the other is epinephrine. So CPR, epinephrine, CPR, epinephrine. And what you have to do, which is very important, is to treat reversible causes. I'll be discussing reversible causes later, but I have to tell you at this point that if you don't treat reversible causes, you are not going to get your patient back. So treatment of reversible causes is extremely important in pulseless electrical activity and asystole. What is pulseless electrical activity? So any rhythm without a pulse. You saw a patient, you check the pulse, there is no pulse, monitor showing any rhythm except for ventricular fibrillation, ventricular tachycardia and asystole. Except for these 3 rhythms, any rhythm on the monitor without a pulse is pulseless electrical activity, and you will have to treat it under that domain. This is the picture of ventricular fibrillation. These are the picture of ventricular tachycardia. The top one is monomorphic ventricular tachycardia because you can see this morphology is same of all the waves. And the bottom one is polymorphic ventricular tachycardia. You can appreciate different morphologies in the bottom one rhythm. So this is sinus tachycardia in the first picture. The second is atrial fibrillation. You can see there is irregular rhythm. RR interval is different throughout. Atrial flutter, see, you can appreciate the sawtooth appearance. And this is supraventricular tachycardia. You can appreciate narrow QRS complex over here. As I have told you earlier, there are 2 types of rhythms, shockable and non-shockable. VFib and pulseless VTAC are shockable rhythm, and asystole and pulseless electrical activity are non-shockable rhythms. So this is cardiac arrest, that is no pulse. So if you have no pulse, you will start CPR immediately. You will attach oxygen and monitor. Monitor will show you rhythm. You will have to assess whether it's a shockable rhythm or non-shockable rhythm. If it's a shockable rhythm, then you will give shock and will resume CPR for 2 minutes. Then again assess for pulse and rhythm. If the pulse is present, then the intervention will be different, but if the pulse is absent, then again you will see rhythm. If rhythm is shockable, then you will give shock and perform 2 minutes CPR again. After 2 shocks have been given, you will give 1 dose of epinephrine, that is 1 milligram. Then you will again assess the rhythm and pulse. If the pulse is absent and the rhythm is shockable, then you will again give shock, and after the 3rd shock you will give amiodarone or lidocaine, and you will resume 2 minutes CPR. If again it's a shockable rhythm, then you will repeat the procedure from here. You will give shock, you will give epinephrine, then you will give shock, then you will give amiodarone, then again shock, then epinephrine, then again shock, then amiodarone, until you achieve the ROSC. In cases of non-shockable rhythms, that is asystole and PEA, you will directly give epinephrine as soon as possible, and then will resume CPR for 2 minutes. After 2 minutes CPR, you will again assess rhythm, if it's shockable or not. If it's shockable, then you will do shock and then epinephrine, then shock, then amiodarone. And if it's a non-shockable rhythm, then you will resume your CPR and give epinephrine. but do remember that you have to treat reversible causes in the scenario of non-shockable rhythms. It's very important. So the components of a good CPR include: the depth should be 5 cm at least and 2 inches. I'm talking about adult patient. The compression rate should be 100 to 120 beats per minute. Interruptions should be minimized to less than 10 seconds. Compressors should switch the position every 2 minutes because they may fatigue and it will result in poor compressions. Allow complete chest recoil to ensure proper heart filling. Compression to ventilation ratio should be 30:2, that is 30 compressions and 2 breaths. But if you have achieved an advanced airway, then you will continue your compressions and the breath will be given at the rate of 1 breath every 6 seconds. So to achieve airway, we can use nasopharyngeal, oropharyngeal and an endotracheal tube. If the gag reflex is present and the patient is conscious or semi-conscious, you have to use nasopharyngeal. You cannot use oropharyngeal because it may result in coughing or vomiting, so you have to avoid it. And if the gag reflex is absent and the patient is unconscious, then you will use oropharyngeal tube. If the patient's respiratory parameters are not achieved by the following, then you will have to proceed to advanced airway. And how to confirm the placement of endotracheal tube? It can be clinical by auscultation, but the confirmatory is via waveform capnography. And after the achievement of advanced airway, as I have told you earlier, you have to give 1 breath every 6 seconds. These are the pictures of oropharyngeal and nasopharyngeal airway. This is a normal waveform capnography shown in the picture. The normal range is 35 to 45 millimeter of mercury. If your waveform is above 45 millimeter of mercury, it means you are hyperventilating the patient and the patient is washing off more carbon dioxide from the body. And if the waveform is less than 35, then it means you are hypoventilating the patient and there is accumulation of carbon dioxide inside the body. So if the waveform shows you 45 and the patient is hyperventilating, what you have to do? You will have to decrease the breathing rate so that you can achieve hypoventilation and you will, optimize the breathing. And in case 35 then and the patient is hypoventilating, then you have to hyperventilate the patient. If waveform is less than 10, then it indicates that chest compressions are not correct and they are not fast or deep enough. So you will have to perform correct chest compressions. These are the important drugs that are used in cardiac arrest and with the doses: epinephrine 1 mg every 3 to 5 minutes, amiodarone 300 mg bolus, and the second dose you use is 150 mg. You have to remember the dose of amiodarone and epinephrine because these are important for exam point of view. And even lidocaine. Lidocaine is 1 to 1.5 mg per kg, but the second dose when you give after other shocks, then you will give 0.5 to 0.75 mg per kg. The reversible causes which needs to be discussed and which needs to be treated in asystole and pulseless electrical activities are H's and T's. In H you have hypovolemia, which is the most common cause, by the way, then hypoxia, hydrogen ion increase, that is acidosis, hypothermia, hyper or hypokalemia. And the T's include tension pneumothorax, tamponade, toxins, pulmonary thrombosis and coronary thrombosis. If you are not going to treat these causes, then it's useless to do CPR. Tachycardia with a pulse. So it will include all tachycardias, including ventricular tachycardia with pulse, and supraventricular tachycardia, sinus tachycardia, and atrial flutter, atrial fibrillation. These all are included. This algorithm I have taken from AHA. So how you are going to manage the tachycardia? Tachycardia, first of all, tachycardia is more than or equal to 150 beats per minute. So assess appropriateness of clinical condition. Heart rates typically more than 150. You have to remember this heart rate. Identify and treat the underlying cause. Maintain airway, assess breathing, oxygen, cardiac monitor to identify rhythm. You have to check blood pressure, as I have told you earlier that management is going to be changed if the blood pressure is normal or it's decreased. IV access to be established and a 12-lead ECG if available. So you don't have to wait for a 12-lead ECG and the other lab work. You just have to assess the patient on the basis of symptoms. So what are the symptoms? Is the patient hypotensive? Is there is acutely altered mental status? Why we are talking about acutely altered? Because in the patients of stroke, chronic stroke, the mental status is mostly altered, so they are excluded. It's acutely altered, a sudden onset of altered mental status. Signs of shock. What are the signs of shock? Patient's blood pressure will drop, patient will be tachycardic, there will be decreased urine output. So if any of these is present, then it's a symptomatic tachy. Any chest pain or signs of acute heart failure. So if they are present, any of the symptom is present, then you will do synchronized cardioversion, and if they are not present, then you will assess QRS complex. If QRS complex is wide, then you will consider adenosine if it's regular and monomorphic, and if it is not regular, then antiarrhythmic can be given. And if QRS complex is narrow, then you will have to perform vagal maneuvers. So vagal maneuvers are important. Then you can simultaneously give adenosine, and beta blockers and calcium channel blockers can be considered, and then expert consultation. So in this box there are doses written of drugs, so you can read bradycardia. So these are the rhythms of different types of bradycardias. The first one is sinus bradycardia with first degree atrioventricular block or heart block. So in this there is progressive lengthening of PR interval, and then there is picture of the second picture is of second degree type 1 AV block. In this block you will see there is progressive PR interval prolongation, and then there will be a skip beat. And the next picture is of second degree type 2 AV block. In this the PR complex is same length, but there is a drop beat, and in third degree there is no relation between ventricular and atrial contraction. So how you are going to treat it? In the first slide which I created as a summary, I told you that you have to assess the pulse, then you have to see if the patient is symptomatic or not. So the same things, you have to maintain the airway, breathing and oxygen, and attach monitor, identify the rhythm, maintain IV access. 12-lead ECG is plus minus. It can be done when the ROSC is achieved or if the patient is stable. And then what you have to do is check for symptoms. Is the patient hypotensive? What's the blood pressure? If its systolic is more than 90, then it's okay, you will monitor and observe. But if it's less than 90, then you need to intervene. Acutely altered mental status, signs of shock, ischemic chest discomfort, acute heart failure signs. So if these are present, then you will give atropine 1 milligram bolus, and then you can repeat it after every 3 to 5 minutes. Maximum 3 milligrams can be given. Then other treatments can involve like transcutaneous pacing and or dopamine infusion or epinephrine infusion. So you have to select any of the following drugs. But what you can do is you can start with atropine, and if it's not settling, then you can add transcutaneous pacing, and if it's still not settling, then you can add dopamine infusion with it. Then you can consider expert consultation, and if there are no symptoms in the patient, then you will have to monitor and observe, and you can also look for other causes. and treat the causes. So the causes of bradycardia are mentioned in this box, which can be myocardial ischemia or infarction, drugs and toxicologic agents such as calcium channel blocker, beta blocker and digoxin, hypoxia and exercise induced hypoxia can be there, electrolyte abnormalities, example hyperkalemia. What is the post cardiac arrest care? So once there is return of spontaneous circulation and your patient is optimized, you need to assess the pulse rate as well and blood pressure. These are very important. So now after the achievement of ROSC, you will manage the airway properly and you will set the respiratory parameters. That is, you keep the saturation from 92 to 98 percentage and the partial pressure of carbon dioxide should be 35 millimeter of mercury. Then you will go for ABGs you can assess the cause from ABGs as well, and a 12 lead ECG is a must then, and other baseline workup to identify the causes. Hemodynamically manage the patient. The goal is 90 millimeter or more systolic blood pressure and a MAP, that is mean arterial pressure, of more than 65 millimeter of mercury. The most important among these is targeted temperature monitoring. It is also important for exam point of view. The targeted temperature monitoring, the temperature should be kept between 32 to 36 degrees Celsius for at least 24 hours. You have to keep it for at least 24. It's very important. Arrange cath lab. If a STEMI or unstable cardiogenic shock, you will go for brain CT and electroencephalograph, and you have to treat the reversible causes HNTs. So these are some important reperfusion points for exam point of view. Door to needle time is 30 minutes. What is needle? The fibrinolysis using medication. First medical contact to balloon inflation, that is PCI, is 90 minutes. For stroke, to minimize time interval for intervention, provide hospital notification and on arrival transport directly to brain imaging suite and bypass ED. Thank you for watching. I hope you liked it. Please like my videos, do share it, and please subscribe to my YouTube channel so that I get motivation to make further such videos. If you have any queries, you can ask in the comment section, and the comment section is also open for any kind of positive or negative feedback. So do comment. Thank you.